fibroids. Uterine fibroids, the evidence-based management and how to deal with it. So uterine fibroids is a very common benign tumor of the female reproductive tract, and it has a lifetime prevalence of 30%. Fibroids are nothing but the overgrowth of the smooth muscle of the uterus. You know what? When I was working in UK, I was working in all the hospitals in London. We used to have every week almost with so many fibroids, different types of fibroid surgeries. I've seen like a lot of fibroids complicating pregnancy. Fibroid is very common among black women compared to white women, especially in the Afro-Caribbean and Africans. It can happen like in the ratio of 3 to 9 when you compare with 1 in a white woman. We don't know why it's very common in the black people, and sometimes we think whether it could be due to genetic reasons. After blacks, it is common in Asians, followed by Caucasians. If you take about the risk factors for fibroids, the risk factors are overweight, when people don't have any children, and majority of the fibroids do not cause any symptoms. About 75% do not cause symptoms. Only 25%, 1 in 4, are symptomatic. The symptom depends on the location of the fibroid and size of the fibroid. And can I have any of the volunteers to tell what are the common symptoms with fibroids? I think it's a very simple question for a postgraduate. You would have seen like loads of patients in your outpatient clinic coming with heavy menstrual bleeding and irregular bleeding, abdominal pain, pelvic pain, pain with periods, and sometimes it can present without symptoms, being diagnosed in a normal ultrasound. Depending on the location of the fibroids, they might have urinary or bowel symptoms. And this diagram was borrowed from the TOG article from the obstetrician and gynecologist. You can see the different locations of fibroids. Recently, I had a case where I had a lady who had about 11 centimeter fibroid complicating pregnancy. Was diagnosed in the viability scan early in the pregnancy. The pregnancy went on very well. She ended up in a cesarean section, but we did not operate on her fibroid, because as you know, fibroids can't be operated during pregnancy. Unless they are on the way, we remove it. Otherwise, we don't, because there is a risk of heavy bleeding during cesarean section. And if you take about the symptoms of fibroid, I already told you, some people will have just a kind of a fullness in the abdomen, dragging sensation, and urinary and bowel symptoms depending on the location of the fibroid. Fibroids are usually common in the reproductive age group. They are rare before menarche and they regress after menopause. Whether you have the provision for all these treatments in your clinic or your hospital, fibroids can be traditionally managed with surgery. In those days, we used to do only myomectomy or hysterectomy. Now we have non-surgical options with medical management, uterine artery embolization, MRI-guided focused ultrasound. In surgery, we have 2 options, namely minimally invasive surgical option or open option. In minimally surgical option, we have hysteroscopic myomectomy and laparoscopic myomectomy. In open procedure, we have open myomectomy and hysterectomy. The type of the treatment is based on the age of the patient, symptoms of the patient, location of the fibroid, type of the fibroid, and patient what she wishes, the cost of the procedure, and the availability in your setting. Can anybody volunteer about what are the pharmacological options, the medical treatment options for fibroid? One of the take-home messages is not all fibroids need surgery. If you don't have any symptoms or if you have minimal symptoms, expectant management may be acceptable. Many of the fibroids, women who do not have symptoms, I have seen have been unnecessarily operated by gynecologists for whatever reason it is. During pregnancy, fibroids can cause what is called as red degeneration during pregnancy, and people have pain. This can be confused with preterm labor, can be confused with other causes of abdominal pain like appendicitis or ovarian cyst accidents, etc. Fibroids women, when they always get worried, will I get pregnant? Not all the fibroids will cause infertility. Sometimes fibroids which are inside the uterus lining, namely the submucous fibroids, they can cause mechanical problem in implantation, which usually needs hysteroscopic resection before proceeding with pregnancy. Sometimes you have fibroids in the subserous area or intramural area, which can cause tubal block. And one of the studies by Dr. Kalouf from Guy's Hospital, he has done a research on whether all intramural fibroids needs to be removed before undergoing fertility treatment. And I have to say that not all the intramural fibroids need surgery, and usually the fibroids which affect fertility are submucous fibroids, or sometimes the subserous fibroids or cornual fibroids, which can affect the tubal block, can cause tubal problem. Fibroids, many women with fibroids always get worried whether they will get pregnant. Fibroids, people can have successful pregnancy. In one of the studies, the median growth of fibroids was 9% over the 6-month observation period. And today, next slide is, I'm going to talk about each of the treatment options in detail. The first treatment option is medical management. In medical management, we usually use the mefenamic acid and tranexamic acid combination, which is the first line of drug. This is used as a temporary measure to control the symptoms and reduce the heaviness of the bleeding, as well as to reduce the pain. In one of the studies, pharmacological treatment options, I'm talking about mefenamic acid and tranexamic acid, the first line of choice for abnormal uterine bleeding, and the maximum the dose we can give is, the tranexamic acid can be given as 1 gram tablets 4 times a day. Mefenamic acid can be given as 500 milligram tablets 3 times a day after food. The medical management of these drugs helps with reduction of blood loss in myomectomy. Especially in myomectomy, we give intravenous tranexamic acid during the time of surgery to reduce the blood loss. Medical management is useful in the infertile patients who want to avoid surgery. It is also useful in people who are approaching menopause, where we are expecting the fibroids to shrink after the menopause, and you're using the medical management temporarily. And we also use medical management to reduce the size of the fibroid and to reduce the bleeding and to improve the anemia. Apart from the medical treatment, first I was talking about non-hormonal treatment. Now about the hormonal treatment, we have the Mirena intrauterine system, which is a levonorgestrel intrauterine system, which is an effective treatment for fibroid. But there is always a controversy regarding whether the when you put a Mirena in a big uterus, whether it's going to expel. And not all the women with big fibroids will be benefited by Mirena. If the uterine size is more than 12 weeks, Mirena is not a good choice. And Mirena can reduce the blood loss during the periods, improve the hemoglobin, relieve the symptoms. But the only problem with Mirena is intermenstrual spotting, which can be there for 3 to 4 months after insertion. That is, when you look into the data regarding the Mirena, there is a lot of reviews, and there is conflicting information on whether Mirena reduces the fibroid volume or the uterine volume. Basically, Mirena secretes the levonorgestrel, which is a progesterone, which makes the endometrium thin. The advantage is we don't need to give orally. It acts locally, avoiding the oral side effects. And there was a randomized controlled trial where they compared 58 women either to combine oral contraceptive or a levonorgestrel system. The trial showed that levonorgestrel system was more effective than combined OCP in reducing the menses and improving the hemoglobin and levels. And there was an increase in the hemoglobin level in the levonorgestrel group compared to the OCP group. And there was also reduced number of bleeding with Mirena. In India, we have Mirena, but the only thing is its cost is around 5,000 rupees. The next medical treatment is GnRH analogs. The GnRH analogs was used initially for the pre-operative management of uterine fibroids before undergoing myomectomy or hysterectomy to reduce the size of the fibroids. And this is a temporary measure. It is not a permanent measure. GnRH analog cannot be used forever because there are side effects. I just wanted to know, in your hospital, do you use Mirena coil commonly for heavy menstrual bleeding? And what is your experience? Anyhow, in my experience, when you have a big uterine fibroid of more than 12 weeks, Mirena coil is not a good choice. If you have multiple fibroids or if you have a distorted uterine cavity, Mirena coil is not a good option. And it is also not a good option for people who are trying to get pregnant. And when if you have a patient who is having mild to moderate symptoms and she does not want surgery, this might help to pull some time. Now, after the Mirena coil, I was talking about GnRH analogs. GnRH analogs, mainly the leuprolide. Leuprolide can be given as a depot every month, every 28 days, or it can be given a 3-monthly depot. GnRH analog is usually used in a pre-operative management when there is anemia, to correct the anemia before surgery, or it can be used for reduction in the size of the fibroids before proceeding with his myomectomy laparoscopically. And it is also used when there are multiple uterine fibroids where you want to do the operation vaginally and where you want to shrink the fibroids, and this can be used as an adjuvant. The only thing is there are side effects with the GnRH analogs, namely the menopausal symptoms, and there is also a time limit of up to 6 months of usage with GnRH analogs. And one of the major side effects is osteoporosis. And one of the Cochrane reviews evaluated the role of preoperative GnRH analog in women undergoing hysterectomy or myomectomy, and they have found out there was 1/3 reduction in the leiomyoma size and improvement in symptoms after 12 weeks. After discontinuation of the treatment, the periods returned back in 4 to 8 weeks. That is 1 to 2 months. The period came back. Fibroid size came back to normal within 4 to 6 months. So overall, there was a 36% reduction, but the fibroid came back to its original size in 4 to 6 months, and the period came back in 1 to 2 months. Preoperative use of GnRH analog may reduce fibroid volume sufficiently to make vaginal hysterectomy or transverse incision for the abdominal approach feasible. So if you're planning to do a laparoscopic assisted vaginal hysterectomy, or if you're going to plan for a laparoscopic myomectomy, GnRH analog will be good. And it's also making the hysterectomy easier, reduces the operating time and a shorter hospital stay. But there's always a debate whether to use GnRH analog. When you're doing lap myomectomy, some of the doctors feel after giving GnRH analog, the plane between the fibroid and the myometrium becomes very difficult, and it will be difficult to dissect. One of the authors reported there was there was a difficulty in operating because of the lack of cleavage plane in fibroid after using GnRH analog. Any one of the doctors, did you have any recent cases of fibroids where you have used GnRH analog? Tell your experience. Namely, now the famous drug which is called as ulipristal acetate. Ulipristal acetate is the selective progesterone receptor modulator, and we also have enough data on ulipristal now. Ulipristal has been used as an emergency contraceptive in the past. Now it's being used in the treatment of uterine fibroids. Basically, it causes apoptosis of the fibroid cells, and it inhibits the proliferation of fibroid cells. There are a lot of research going on ulipristal. It reduces the bleeding in over 90% of the patients. There are 3 trials were being done in ulipristal: Pearl 1 trial, Pearl 2 trial, and Pearl 3 trial. Pearl 1 trial compared ulipristal along with the dosage of 5 mg and 10 mg with a placebo. In Pearl 1 study, they compared ulipristal 5 mg and 10 mg along with a placebo. Basically, what they found was the period loss was reduced in more than 90% after 13 weeks of treatment, and mostly within 10 days, people had no periods. They became amenorrheic, and the fibroid volume changed by 41% compared to placebo. But this reduction was not maintained for at least 6 months. Basically, Pearl 1 compared placebo with uterine ulipristal, and they found out it helped with the reduction in the uterine volume, and they became amenorrheic. Pearl 2 is the study where they compared ulipristal along with GnRH analog, and this was a double-blinded trial for 13 weeks where people had monthly depot of GnRH analog, and what they found was there was no difference and ulipristal was tolerated better, and fibroid volume change was more with GnRH analog. The only problem with GnRH analog was more side effects. But when you compare the menses, there was no change, but the fibroids was more shrunk with GnRH analog. And Pearl 3 I have not written here. Pearl 3 is where they compared long-term use of ulipristal with repeated treatments of ulipristal at the dosage of 10 mg. And what they found out was repeated use of ulipristal did not have much side effects. And in the Pearl 3 trial, they used 4 times repeated ulipristal in an interval with interval gaps. They also used norethistérone in between the courses, and there was no effect on the progesterone receptor modulated endometrial changes. Basically, the aim of ulipristal is to make the endometrium, the apoptosis of the uterine fibroids. And we don't have much long-term data of the effect of ulipristal on other organs like the breast, bone, brain, etc. This all needs to be researched. And when we talk about the medical management, we also have the other treatments, namely selective estrogen receptor modulators, namely the raloxifene, as well as aromatase inhibitors, which is being used for ovulation induction, namely the letrozole. And when you look into the evidence, there is limited evidence of usage of both SERMs as well as letrozole in fibroids. And the treatment with letrozole is experimental, it's not recommended. Next, we go about the uterine artery embolization, which is introduced in 1994. And there was a randomized control trial comparing 177 patients of uterine artery embolization with hysterectomy. What they found out was after uterine artery embolization, people had minor complications, but not many major complications. They had a shorter hospital stay, but there was increase in readmission rate after uterine artery embolization, mainly due to pain factor. I have personally seen patients being treated after uterine artery embolization who come back and get admitted because, and sometimes if you have multiple fibroids, it takes months before the fibroid gets degenerated and myolized, and people can have abnormal white discharge. And one of the Cochrane reviews found there was a better patient satisfaction with uterine artery embolization, and there was a quicker recovery and early return to work. And they also found out there was fivefold increase in intervention within 2 to 5 years. There was no difference in ovarian failure rates comparing uterine artery embolization and hysterectomy. Any questions regarding uterine artery embolization? Does anybody have any of the personal experience on it? Basically, the interventional guided procedure where through fluoroscopy they embolize the uterine artery, which gives the blood supply to the fibroids. And this is not an ideal treatment for people who want to get pregnant, but there are reported pregnancy after uterine artery embolization, and there was also live births reported after uterine artery embolization. In one of the studies, 66 women, 26 were treated with uterine artery embolization, 40 were treated with myomectomy. There was no difference in the live birth rate between myomectomy and uterine artery embolization. The most common side effects were post-procedure pain and vaginal discharge, which is common after uterine artery embolization. And unfortunately, there are some studies where people have died after uterine artery embolization. But the mortality rate with uterine artery embolization is 1 in 10,000, compared with 3 in 10,000 with hysterectomy. And there is another study called Hopeful Study, where there are data available for 5 years follow-up after uterine artery embolization or hysterectomy, and both were considered to be safe. Uterine artery embolization has a lower rate of major complications, but it has an increased rate of minor complications and re-intervention. Basically, the take-home message is uterine artery embolization is a non-invasive technique. It can be done as an outpatient. There are no increase in major complications. There have been reported pregnancies. The only complication is the person can have abdominal pain post-procedure and vaginal discharge. And there are data 5 years follow-up after uterine artery embolization, and both were considered to be safe. But there is a risk of mortality, which is 1 in 10,000 after uterine artery embolization, compared with 3 in 10,000 with hysterectomy. The next non-invasive technique is MRI guided focused ultrasound, where we use high-frequency ultrasound waves to denature the protein in the fibroid, causing cell death, necrosis, and shrinkage. It is not recommended for fertility patients, and it is helpful for people who want to preserve the uterus. And of course, MRI guided focused ultrasound is not a permanent procedure, and patients do have satisfaction after the procedure. There is a quick recovery, there is a low morbidity, but this is a new upcoming treatment for fibroids. But we do not have enough data regarding whether there is a safety for people who want to have future children. And there was a intervention rate of 25% after MR guided focused ultrasound. But the patient satisfaction was good after MR guided focused ultrasound. Next, we are going to talk about the surgical treatment options for fibroid. Surgical treatment options is recommended for people who have symptoms, people who are not responsive to medical treatment, or when you have submucous fibroid, or you have large pedunculated subserous fibroid where you can do lap myomectomy. And people who have completed the family, we can do hysterectomy. Myomectomy can be done either through hysteroscopy or through laparoscopy or through open approach. And the best, of course, will be a minimally invasive treatment for which you need surgical expertise and also the cost factor. And when you talk about the fibroids, mainly the submucous fibroid is much interest to an infertility doctor. and submucous fibroids can cause mechanical problem in implantation. And we have lots of classification on submucous fibroids, namely the European Society of Gynecological Endoscopy, and as well as Federation of International Gynecology and Obstetrics, FIGO, what we call FIGO. When you talk about type 0 is the best fibroid, where the entire fibroid is in the endometrium. There is no myometrial involvement. There is type 0, where the whole fibroid is within the cavity. There is no myometrial involvement. And type 1, where there is myometrial involvement but is less than 50%. And type 1, you have another type with the subtype where the extension in the myometrium is more than 50%. So when you see the angle between the fibroid and the uterus, angle will be less than 90. And the third type 2 fibroid is the type 0 is entirely endometrial. Type 2 is partly intramural, partly within the myometrium, but the extension is less than 50%, more than 50%, and more than 50% is type 2. And FIGO, we also have like type 0, which is entirely within the cavity. Type 1 is less than 50% intramural. Type 2 is more than 50% intramural. Type 3 is entirely intramural. And there are also classifications subserosal and can be partly subserosal, partly intramural, etc., etc. So the best classification, we don't know which is the best one. The most widely used, if you see, is the European Society classification. There are also, when you see about the submucous fibroid incidence, submucous fibroid is present in 6 to 34% of people with heavy abnormal uterine bleeding. It is present in 2 to 7% of infertile patients, and 1 to 5% of submucous fibroid can be asymptomatic. We also have different types of classification of fibroids, submucous fibroids, depending on the size of the fibroid, depending on the extent, penetration in the lateral wall, etc. And if you have a patient, the type of surgery depends on the location of the fibroid, size of the fibroid, the symptoms of the fibroid, etc. Apart from the myomectomy, we also have myolysis, and where the fibroid, instead of being resected, is with the electric current, we pass a needle through the fibroid, and this causes myolysis. We can also use a freezing probe in a similar manner. We also have myomectomy and hysterectomy. We have a data where the data was a systematic review where they compared myomectomy versus hysterectomy. When they compared, there was no difference in major complications, where there was high bleeding in hysterectomy group, but there was no difference in blood transfusion. When they compared minimally invasive approach with open approach for myomectomy, laparoscopy is always better because there is less postoperative pain, better recovery, less bleeding, less hemoglobin drop, less overall complication. Only problem is more operating time and surgical expertise needed. Laparoscopic wise open major complications, the pregnancy rate was same, major complications were same, and recurrence was also the same. So in essence, when we compared hysterectomy with myomectomy, there was no difference in the major complications between both the groups. There was a lot of bleeding in the hysterectomy group. When they compared the minimally invasive group with open group, minimally invasive group was much better. The only problem was long operating time. When they compared the recurrence rate, pregnancy rate, and major complications, both were same between laparoscopic approach and open approach. Hysterectomy is a gold standard treatment for fibroids. This is a permanent treatment. The only problem is hysterectomy is a major procedure. It involves complications. There's also a cost factor, and the choice of the surgery depends on the size of the uterus, surgical expertise, and whether there is uterine descent. And open approach traditionally used or total laparoscopic or lap-assisted vag hyst. Conclusion. In conclusion, we have MR guided focused ultrasound, which is useful to elevate the symptoms of fibroid, and this is outpatient procedure. and it is it's not a permanent procedure, but this can be used for if you have the MRI facility, and basically this causes the denaturation of proteins. And surgery is for submucous fibroid, the gold standard is hysteroscopic resection. If you have a subserous pedunculated fibroid, you have lap myomectomy, and we have successful pregnancies reported both after uterine artery embolization and MRI guided focus ultrasound. But however, these are not the treatment of choices. And with regard to the new technology of MR guided focused ultrasound and the safety for future childbearing, we need some more information. And we also have the new drug, namely the ulcipristol, which is selective progesterone receptor modulator, which is being used for symptomatic control and reduction in size of fibroids. And we have research established for repeated use of ulcipristol, namely the PEARL-3 study. I hope the presentation was useful, and the candidates, there was no response from the other side, and if you have any questions, you can throw at me. Can I ask some questions? Can they answer some? I mean, they don't have questions. Can I ask them some? The ablation is not a proper treatment for fibroid. It is only if you have a fibroid, like a little fibroid, where and the people is perimenopausal or like approaching menopause, this can be used to treat the heavy menstrual bleeding. But it is not an ideal treatment for fibroid. Hysteroscopic resection of fibroid is the correct operation. But you have a very little kind of seedling fibroid or something, then you can just do it.